So today we will start with esophagus. First of all, we will study about the normal structure of the esophagus. So esophagus is a muscular tube extending from the pharynx to the stomach. In an adult, this distance measures 25 centimeters. The distance from the incisor teeth to the gastroesophageal junction is about 40 centimeters. The region of proximal esophagus at the level of prepharyngeal muscle is called as the upper esophageal sphincter, while the portion adjacent to the anatomical G junction is referred to as lower esophageal sphincter. Histologically, the wall of this esophagus consists of mucosa, submucosa, muscularis propria, and adventitia, or also known as serosa. Now, the mucosa is composed of non-keratinizing stratified squamous epithelium overlying lamina propria, except at the lower end for a distance of 0.5 centimeters. The basal layer of the epithelium may contain some melanocytes, argyrophil cells, and Langerhans cells. At the lower end of the esophagus, there is sudden change from stratified squamous epithelium to mucin secreting columnar epithelium, and which is also called as the junctional mucosa. After mucosa and the submucosa, it consists of loose connective tissue with sprinkling of lymphocytes, plasma cells, and occasionally eosinophils and mast cells. Mucus-producing glands are also scattered throughout the submucosa. Now, the muscularis propria, it is composed of two layers of smooth muscle, an inner circular coat and an outer longitudinal coat. The proximal portion of esophagus contains skeletal muscle fibers from prepharyngeal muscle. The parasympathetic nerve supply by the vagus nerve is in the form of extrinsic and intrinsic plexuses. The adventitia serosa is the outer covering of the esophagus. Serosa is present in intra-abdominal part of esophagus only, while elsewhere the periesophageal adventitia covers it. The major functions of esophagus are swallowing by peristaltic activity and prevent the flux of gastric contents into the esophagus. Now we will study about the muscular dysfunctions. So these are the disorders in which there is motor dysfunction of the esophagus and manifested clinically by dysphagia. These include achalasia, hiatus hernia, esophageal diverticulum, the valves and the rings. Achalasia, which is also known as cardiospasm. Achalasia of the esophagus is a neuromuscular dysfunction due to which the cardiac sphincter fails to relax during swallowing and results in progressive dysphagia and dilatation of the esophagus, which is also known as the megaesophagus. The etiology of achalasia. There is loss of intramural neurons in the wall of the esophagus. Most cases are of primary idiopathic achalasia, that is congenital. Secondary achalasia may occur from some other causes, which include Stargardt's disease, which is caused by trypanosoma cruzi, infiltration into esophagus by gastric carcinoma or lymphoma, certain viral infections, and neurodegenerative diseases. Hiatus hernia. It is a herniation of protrusion of part of the stomach to the esophageal hiatus of the diaphragm. Esophageal hiatal hernia is the cause of diaphragmatic hernia in 8% of cases. The condition is diagnosed radiologically in about 5% of apparently normal asymptomatic individuals. In symptomatic cases, especially the elderly men, the clinical features are heartburn and regurgitation of gastric juice into the mouth, both of which are worsened due to heavy work, lifting weights, and excessive bending. So here in this diagram, we can see the patterns of hiatus hernia. The A diagram is sliding type, B is rolling type here, and C is mixed, which is also known as transitional type. Morphologic features. There are three patterns in hiatus hernia: sliding or esophagogastric hernia, rolling or paraesophageal hernia, mixed or transitional. So in sliding, this is the most common type, and it occurs in almost 85% of cases. The herniated part of the stomach appears as supradiaphragmatic bell due to sliding up on both sides of the esophagus, as we had just seen in the diagram. Rolling type, it is seen in 10% of cases, and this is a true hernia in which cardiac end of the stomach walls are paraesophageal, producing an intrathoracic sac. The third type is the mixed or the transitional type, which constitutes the remaining 5% cases in which there is combination of sliding and rolling hiatus or now the esophageal diverticula. So diverticula are the outpoutings of the esophageal wall at the point of weakness. They may be congenital or acquired. Congenital diverticula occur either at the upper end of the esophagus or at the bifurcation of trachea. Acquired diverticula may be of two types, Pulson or the Zenger's type, which is seen in the region of hypopharynx or and occurs due to esophageal obstruction such as due to chronic esophagitis, carcinoma, etc. The mucosa and the submucosa herniate through the weakened area or through the defect of the muscularis propria. Second one is the traction type. It occurs in the lower third of esophagus from contraction of fibrous tissue, such as from bleeding lesions, scar tissue of heels, tuberculosis lesions in the hilum, and silicosis, etc. Complications of diverticula include obstruction, infection, perforation, hemorrhage, and carcinoma. Now the ectopia. So ectopic tissues or the developmental risks are common in the gastrointestinal tract. The most frequent site of ectopic gastric mucosa is the upper third of the esophagus, where it is referred to as the inlet patch. Although the presence of such tissue generally is asymptomatic, acid released by gastric mucosa within the esophagus can result in dysphagia, esophagitis, Barrett's esophagus, or rarely adenocarcinoma. Gastric heterotopia. Small patches of ectopic gastric mucosa in the small bowel, particularly within a mecal diverticulum or colon, may present with occult blood loss due to local injury caused by acid reflux. So these are the hematemesis of esophageal origin. So massive hematemesis, vomiting of blood, may occur due to vascular lesions in the esophagus. These lesions are as under esophageal varices. Esophageal varices are tortuous, dilated, and engorged esophageal veins seen along the longitudinal axis of esophagus. They occur as a result of elevated pressure in the portal venous system, most commonly in cirrhosis of liver. Less common causes are peritoneal venous thrombosis, hepatic vein thrombosis, also known as Vaquiara syndrome. Lesions occur as a result of bypassing of portal venous blood from the liver to the esophageal venous plexus. The increased venous pressure in the superficial veins of the esophagus may result in ulceration and massive bleeding. Second is Mallory Weiss syndrome. In this condition, there are lacerations of mucosa at the GE junction following minor trauma such as by vomiting, retching, or vigorous coughing. Patients present with upper gastroesophageal bleeding. So this is the picture of esophageal varices. The first one is the angiogram, which showing several tortuous esophageal varices. B is the angiogram is striking. The endoscopy is more commonly used to identify varices. So B is the diagram from the endoscopy, whereas A is the angiogram. In C, we can see collapsed varices are present in the post-mortem specimen corresponding to the angiogram in A. Here, you can see this. The polypoid areas are sites of variceal hemorrhage that were ligated with bands. Okay. So in D, dilated varices beneath intact squamous mucosa. Rupture of the esophagus. So rupture of the esophagus may occur following trauma during esophagoscopy, indirect injury. That is, it may be due to sudden acceleration and re-acceleration of the body and spontaneous rupture. For example, after overeating, extensive aerophagy, etc. The other causes can be esophageal hematemesis may also occur in the following conditions. Bursting of aortic aneurysm into the lumen of esophagus, vascular erosion by malignant growth in the vicinity, hiatus hernia, esophageal cancer, or plurals, and hemophilia. So now we will study about the inflammatory lesions of the esophagus. Inflammation of the esophagus are esophagitis, which happens most commonly from the reflux, although a number of other clinical conditions and infections may also cause esophagitis. So here we will see to the esophagitis, the reflux esophagitis. Reflux of the gastric juice is the commonest cause of esophagitis, pathogenesis, gastroesophageal reflux. Um, to an extent may occur in normal healthy individuals after meals and in early pregnancy. However, in some clinical conditions, the gastroesophageal reflux is excessive, resulting in the inflammation of the liver esophagus. So these conditions are as under sliding hypersomnia, chronic gastric and duodenal ulcers, nasogastric intubation, persistent vomiting, surgical bigotry, neuropathy in alcoholics, diabetics, and esophagogastrostomy. The morphologic features. Endoscopically, the demarcation between normal squamous and columnar epithelium at the junction of mucosa is lost. The affected distal esophageal mucosa is red, erythematous prevalent, bleeds and rash. In advanced cases, there are features of chronic disease such as nodularity, strictures, ulcerations, and erosions. Microscopically, the reflux changes in the distal esophagus include basal cell hyperplasia and deep elongation of the papillae touching close to the surface of epithelium. Inflammatory changes vary according to the stage of the disease. In early stage, mucosa and submucosa are infiltrated by some polymorphs and eosinophils. In chronic stage, there is lymphocytic infiltration and fibrosis of all the layers of the esophageal wall. Other causes of esophagitis are infective and non-infective. So infective causes, there are a number of opportunistic infections in immunosuppressed individuals which can cause esophagitis. So some of them are Candida, herpes simplex, cytomegalovirus, and TB. In the non-infective causes, eosinophilic esophagitis is caused by radiation corrosives, intake of certain drugs like anticholinergics, doxycycline, tetracycline, injection of hot irritating fluids, Crohn's disease, and various vestibular skin diseases. Now, the Barrett's esophagus. Barrett's esophagus is a complication of chronic GERD that is characterized by intestinal metaplasia within the esophageal squamous mucosa. Third is gastroesophageal reflux disease. The incidence of Barrett's esophagus is rising. It is estimated to occur in as many as 10% of individuals with symptomatic GERD. White males are affected most often and typically present between 40 and 60 years of age. The greatest concern of Barrett's esophagus is that it confers an increased risk for development of esophageal adenocarcinoma. Molecular studies suggest that Barrett's epithelium may be more similar genetically to adenocarcinoma than to normal esophageal epithelium, consistent with the view that Barrett's esophagus is a direct precursor of cancer. In keeping with this, epithelial dysplasia is considered to be a pain-basal lesion, and it develops in 0.2 to 1% of individuals with Barrett's esophagus each year. Its incidence increases with duration of symptoms and increase in patients' age. Morphology. The Barrett's esophagus is recognized endoscopically as tangles or patches of red velvety mucosa extending upward from the gastroesophageal junction. This metaplastic mucosa alternates with residual smooth, pale, squamous esophageal mucosa proximally and interfaces with light brown columnar gastric mucosa distally. High resolution endoscopes have increased the sensitivity of Barrett's esophagus detection. Most experts require both endoscopic evidence of abnormal mucosa above the gastroesophageal junction and histologically documented gastric or intestinal metaplasia for diagnosis of Barrett's. The defining feature of intestinal metaplasia and the feature of Barrett's esophagus is the presence of goblet cells. So this is very important, which are distinct mucous vacuoles that stain pale blue by HME and impart the shape of a wine goblet to the remaining cytoplasm, which we will see in the figure. Dysplasia is classified as low grade or high grade on the basis of morphologic criteria. Intramucosal carcinoma is characterized by invasion of neoplastic epithelial cells. So this is the image of Barrett's esophagus. So this is gross image. Only a few areas of base squamous mucosa remain within the predominantly metaplastic reddish mucosa of the distal esophagus. Histologic appearance of the, in C we can here see the histological appearance. So there is G junction in Barrett's esophagus. Note the transition between the esophageal squamous mucosa and metaplastic mucosa containing goblet cells. So these are the goblet cells. Here in Barrett's esophagus, the central part of the image shows a squamous mucosa bounded on either side by metaplastic columnar. Here, the metaplastic columnar mucosa showing anaplastic chain in micropapillary pattern. These are the micropapillary pattern of adenocarcinoma. In box shows goblet cells. These blue color structure are the goblet cells in the metaplastic columnar epithelium, which are stained positive for H. Now the esophageal tumors, two morphology variants account for a majority of esophageal cancers, adenocarcinoma and squamous cell carcinoma. Worldwide, squamous cell carcinoma is more common, but adenocarcinoma is again on the rise. So etiology, although exact etiology of carcinoma of the esophagus is not known, a number of conditions and factors have been implicated as other. First of all, it is about the diet and personal habits, which includes heavy smoking, alcohol consumption, intake of foods contaminated with fungus, nutritional deficiency of vitamins and trace elements, esophageal disorders, esophagitis, achalasia, hyperscholia, diverticular, plumber syndrome. Third one is about the risk factors, which includes race and family history. So it is more common in Chinese and Japanese people rather than the Western races, and in fact more common in blacks than whites. In family history, it has association with tylosis, keratosis palmaris, and lentalis. Genetic factors which include predisposition with celiac disease, epidermolysis bullosa, tylosis, HPV infection. It is a recent addition in etiologic factors. At molecular level, abnormality of P53 tumor suppressor gene has been found associated with a number of above risk factors, notably with consumption of tobacco and alcohol, and in cases, proven Barrett's esophagus. Morphologic features: carcinoma of the esophagus is mainly a two-type squamous cell, which is epidermoid and adenocarcinoma. So the benign tumors of the esophagus are uncommon and small in size, like less than 3 centimeters. The epithelial benign tumors project as intraluminal masses arising from squamous epithelium or from columnar epithelium adenoma. The stromal or mesenchymal benign tumors are intramural masses such as leiomyoma and others like lipoma, fibroma, neurofibroma, rhabdomyoma, lymphangioma, and hemangioma. Now the adenocarcinoma. Esophageal adenocarcinoma typically arises in a background of Barrett's esophagus and long-standing GERD. Risk of development of adenocarcinoma is greater in patients with documented dysplasia and in those who use tobacco, are obese, or who have had previous radiation therapy. In the United States, esophageal adenocarcinoma occurs most frequently in whites and shows a strong gender bias, being 7 times more common in male than in women. So, about the pathogenesis, molecular studies suggest that the progression of Barrett's esophagus to adenocarcinoma occurs over an extended period through a stepwise acquisition of genetic and epigenetic changes. This model is supported by the observation that epithelial clones identified in non-dysplastic Barrett's metaplasia persist and accumulate mutations during progression to dysplasia and invasive carcinoma. Chromosomal abnormalities and TP53 mutations are often present in the early stages of esophageal adenocarcinoma. Morphology: esophageal adenocarcinoma usually occurs in a distal third of the esophagus and may invade the adjacent gastric cardia. While the early lesions may appear as flat or raised patches and otherwise intact mucosa, later tumors may form large exophageal masses, infiltrate diffusely or aspirate and invade deeply. On microscopic examination, Barrett's esophagus frequently is present adjacent to the tumor. Tumors typically produce mucin and form glands, which we will see in the figure. So, clinical features, maybe we can see the figures first. Esophageal adenocarcinoma. The A is the gross picture and the B is histopathologic. In A, we can see adenocarcinoma distally, and in this case often involves the gastric cardia. In B, esophageal adenocarcinoma going as back-to-back glands. These are the glands. Okay. So clinical features include pain or difficulty in swallowing, progressive weight loss, chest pain or vomiting. By the time signs and symptoms appear, the tumor usually has a limited submucous lymphatic vessels. As a result of the advanced stage of diagnosis, the overall 5-year survival rate is less than 25%. By contrast, 5-year survival approximates 80% in the few patients with adenocarcinoma limited to the mucosa or submucosa. Now, the squamous cell carcinoma. In the United States, esophageal squamous cell carcinoma typically occurs in adults older than 45 years of age and affects males 4 times more frequently than females. There is factors for squamous cell carcinoma include alcohol and tobacco use, poverty, costing esophageal injury, plumber Wilson syndrome, frequent consumption of very hot beverages, and previous condition for the intestine. There is nearly 6 times more common in Americans than in whites, a striking risk disparity that cannot be accounted for by differences in race of alcohol and the incidence of esophageal squamous cell carcinoma can vary by more than 100-fold between being more common in rural and underdeveloped areas. The countries with highest incidences are Iran, Central China, Argentina, Brazil, and South Africa. So, squamous cell epidermoid or the carcinoma as it is continued. So, squamous cell carcinoma comprises 90% of primary esophageal cancers, which is exceeded in incidence by carcinoma, colon, rectum, and stomach amongst all the GI cancers. The disease occurs in 6 to 7 decades of life and is more common in men than women. The sites of predilection are the 3 areas of esophageal constrictions. Half of the squamous cell carcinomas of esophagus occur in the middle third, followed by lower third and the upper third of esophagus in that order of frequency. Grossly, 3 types of patterns are recognized. First is polypoid or fungating type, which is the most common, and it occurs as cauliflower type, like tribal mass protruding due to the lumen. Second is ulcerating type, which is the next common, and it looks grossly like a necrotic ulcer. Third one is the diffuse and infiltrating type, which appears as an annular stenosis remnant of the wall of the esophagus. So here we can see the 3 types. This one is the polypoid or the fungating, which is coming into the lumen. This is ulcerating type, and this is diffuse infiltrating. So here we can see that the squamous cell carcinoma, it is most common in the middle third. Okay, and this is the distribution for adenocarcinomas. Now microscopically, majority of the squamous cell carcinomas of the esophagus are well differentiated or moderately differentiated. Rectal cells, keratin formation, and epithelial folds are commonly seen. However, non-keratinizing and anaplastic growth patterns can also happen. Pathogenesis, a majority of esophageal squamous cell carcinomas in Europe and the United States are at least partially related to the use of alcohol and tobacco, the facts of which synergize to increase risk. However, esophageal squamous cell carcinoma also is common in some regions where tobacco and alcohol are uncommon due to some religious or societal norms. In these areas, other features, the other factors are important rather than alcohol or tobacco, which are nutritional deficiency, exposure to polycyclic hydrocarbons, nitrosamines, and other mutagenic compounds like those found in fungus, contaminated food, lesions and are suspected to be risk factors. HPV infection has also been implicated in esophageal SCC in high risk, but not in low risk regions. Okay? So, um, in contrast to the distal location of most adenocarcinomas, half of the squamous cell carcinomas occur in the middle third of the esophagus. Squamous cell carcinoma begins as an in situ lesion in the form of a squamous dysplasia. Early lesions appear as a small gray white plaque-like thing. Over months to years, they grow into tumor masses that may be polypoid or protrude into and obstructing the lumen. Other tumors are either ulcerated or diffusely infiltrated lesions that is spread within the esophageal wall where they can cause thickening, rigidity, and pulmonary hemorrhage. These cancers include surrounding structures, including the respiratory tree, causing pneumonia, the aorta, causing catastrophic exsanguination, or the mediastinum and the pericardium. So here we can see the squamous cell carcinoma of esophagus. A shows the gross appearance. The tubular structure has thick muscle in its wall and has longitudinal muscle bones. There is a concentric circumferential thickening in the middle uh, at, at this arrow, which is causing narrowing of the lumen. So here we can see that the lumen is constricted. Okay, the mucosal surface is also ulcerated, as you can see. B shows the photomicrograph of walls of anaplastic squamous cells. These are the walls invading the underlying soft tissue. So these are the anaplastic tumor cells, squamous walls of keratin cells, and they have already invaded the basement membrane. So this is invasive type. Here we can see esophageal. Yeah, this is again the picture of. So this is on the gross. Uh, it is most, as we know, that squamous cell carcinoma is most frequently found in the middle of the esophagus, where it commonly causes strictures, as we had seen in the previous picture also. And here also we can see the nests of the malignant cells that partially recapitulate the stratified organization of the squamous. Now the clinical features, clinical manifestations of a squamous cell carcinoma of the esophagus begin insidiously and include dysphagia or dinophagia, which is pain and swelling and obstruction. As with other forms of esophageal obstruction, patients may unwittingly adjust to the progressively increasing obstruction by altering their diet and solid liquid. Extreme weight loss and debilitation may occur as consequence of food impaired nutrition and tumor-associated cachexia. As with adenocarcinoma, hemorrhage and sepsis may accompany tumor ulceration. Occasionally, squamous cell carcinoma of the upper and right esophagus present with symptoms caused by aspiration of food via rectal esophageal fistula. Increased use of endoscopic screening has led to early diagnosis of esophageal SCC. Early detection is critical because 5-year survival rate are 75% for patients with superficial esophageal carcinoma, but much lower for patients with more advanced tumors.